What physical therapists need to know about femoral acetabular impingement syndrome. All right, just to summarize what we're going to go over in this video, we're going to go over definitions of FAI, the prevalence and incidence, common populations where you'll see it, the functional anatomy, the relevant anatomy, risk factors for acquiring FAI, pathophysiology or mechanism of injury. Basically, how do we acquire this over the course of time? Clinical examination, what kind of objective tests we use for these folks, what kind of subjective findings will they tell us that lead us to diagnosing this accurately? And then we'll talk a little about treatment. So we'll talk about conservative treatments like physical therapy, as well as surgical interventions. My name is Dan Pope, and this is Kevin Coughlin. We are physical therapists at Champion PT and Performance. We've helped to make thousands of incredible coaches and clinicians through online courses, communities, and mentoring programs. And the goal of today's video is to make you 1% better. What's going on, Kevin?
Not much. Very excited to dive into the hip here. I think we finished our, maybe finished is the wrong word. We'll see if we come back to it, but our long segment on knee podcasts. So excited to dive into the hip here and kind of kick it off with FAI.
Yep. FAI is probably my favorite hip injury. So let's start with some definitions. And this is coming from the Warwick Agreement in 2016. So basically had a bunch of really smart rehab professionals and surgeons who got together to discuss what FAI actually is. And the consensus was FAI syndrome is a motion-related clinical disorder of the hip. The triad of symptoms, clinical signs, and imaging findings represents symptomatic premature contact between the proximal femur and the acetabulum. And the reason why they created this definition was because there are a lot of folks who have asymptomatic issues within the hip. We'll talk about what those are in a minute, and they have no symptoms whatsoever. So in order to diagnose FAI, you need to have these three things there from a diagnosis perspective. Let's talk a little about prevalence and incidence. So this is coming from a study from Hale et al. In 2021. The incidence of FAI has increased over the past several years. It's been on the rise since 2000. There's essentially 54.4 diagnoses per 100,000 person years. I'd look this up because I didn't know what the heck this meant. So if you take 100,000 people and you follow them for 1 year, 54.4 folks are going to acquire FAI over this time period, right? And one of the things I will say, we haven't noted this yet, but we're getting better at diagnosing this. We used to be absolutely terrible at diagnosing this. So I think what's happening is you're seeing this is on the rise, and this could potentially be because we have more young athletes playing sports, but also might be just because we're diagnosing it more, right? So I think that's important to just keep in mind. It's not like this is happening at a much higher rate than used to. We just weren't good at diagnosing this in the past. Peak incidence is going to be somewhere between 18 and 35 in women, and a little bit younger, 19 and 25 in men. Generally speaking, this is mostly unilateral, although 21% of patients presenting for FAI surgery have bilateral symptoms. And I've heard this a lot from surgeons. I don't think it's a good thing to tell your patients, but when folks go in for FAI surgery, oftentimes the doc will tell them it's only a matter of time until you get the second one done, which is a terrible thing to say. But it is true in that you are going to see a decent chunk of folks have FAI on one side and they have FAI on the other. And unfortunately, I've seen a lot of folks get surgery for both. It just happens sometimes. It's also very commonly asymptomatic. Some of these numbers are absolutely staggering. Allen et al. In 2019 showed 78% of patients presenting with painful FAI have radiographic evidence in the contralateral hip. So almost all folks have FAI on both sides, or they have the radiographic findings on both, but FAI, they don't have the clinical symptoms on both. And 30 to 60% of the general population presents with radiographic evidence of FAI, but not actually the clinical symptoms, right? So a high percentage of folks are asymptomatic.
Hey there, Broseph McJoseph. I hope you like treats. Evidence-based treats, that is. It's an evidence-based cheat sheet for diagnosing and treating femoral acetabular impingement. Now, not everybody loves searing hip pain right through the front of the hip as much as I do. And if you want to make any money as a physical therapist, you're going to have to help patients with this type of hip pain. Trouble is, got to stay up to date on this condition to know how to treat it properly. And that's where I come in. With this handy-dandy little cheat sheet, we'll catch you up to date on the medical literature on femoral acetabular impingement syndrome in under 10 minutes. We go over a lot of good stuff. Definitions, prevalence, incidence, population, anatomy, risk factors, pathophysiology, mechanism of injury, clinical examination, differential diagnosis, and treatments like physical therapy, injections, and surgery. Best of all, this is a free download. I'll leave a link in the description. Go ahead and download it and get your learn on. And now back to this video.
Any thoughts on that before we move on, Kevin?
That stuff's always so interesting to me, and just definitely makes me think what tips these folks off to where they have their anatomy that looks like impingement. And like you said, you need that clinical report of pain to consider it FAI. Like, when does it become painful? Is it activity dependent? Is it anatomy dependent? I think we're still trying to figure these things out. But one of the things that was interesting that you said there is that about just bilateral symptoms. I actually have a guy on my caseload right now, college soccer player, who had both done at the same time, which is pretty crazy. I've seen people with both done at different times, but he had both done at the same time. And he's doing fairly well. So yeah, it's kind of crazy, but I guess that's something you'll see out there. So definitely the first time I've seen that. Have you seen it both done at the same time?
No, it's pretty amazing. Was he in a wheelchair in
Yeah.
the beginning? Was there a period 9-weight
Well,
bearing?
so
Or-
he lives in New Jersey. So he had the surgery done in New York, and he did the very early post-op there. And he first came to champion at 6 weeks out. And at that point, he was walking, but just definitely limping on both sides, like very wide base of support gait. When he turns, he just like pivots, like it's like a 5-point turn. But yeah, it's pretty funny. And you know, he's doing well, and he's really not in pain right now. He just feels tight, but he
yeah.
probably was in a wheelchair early on, I would guess.
Yeah, that's pretty interesting. Yeah. So cool person. All
Yeah.
right, great. So, what common populations are you going to see FAI in? Generally speaking, it's in young athletes, and it's usually with high intensity sports. And these are sports like soccer, hockey, basketball, and football. When I hear high intensity sports, I don't often think that that's the best way to describe them, but I think sports have a lot of cutting, pivoting, running. That's where you're going to see FAI, right? And it's pretty interesting. So cam morphology, which can be an aspect of FAI, we'll talk about what that is in a minute, is going to be 2 to 8 times more common in athletes versus non-athletes. So essentially, this is something that's probably acquired by playing sports, these high intensity sports, while an athlete is developing. So kind of interesting to hear that. What is the relevant anatomy in folks that have FAI? So if you're not watching this on YouTube, I do recommend you check it out at some point because we have some images to help you out here. So you have the pelvis, right? And the pelvic portion of FAI is going to be the acetabulum or the socket. You have the femur, so more specifically the femoral head or the ball and socket, right? Then you have your labrum, which is a ring of cartilage that surrounds the acetabular rim, and this forms a suction seal. So essentially, if you don't have a hip labral tear, you have an intact labrum, this creates a suction seal around the hip, right? Like a gasket. I'm not a big car guy, so I don't necessarily know what that means, but if you do know cars, I think that'll make more sense. And what this does is it reduces shear and shock absorption, right? What's kind of interesting is you have a layer of fluid between the femoral head and the acetabulum. So when you have an intact labrum, you're essentially walking on water. And the idea is that once you tear your labrum, you lose this suction shear, and now you can't absorb the shock absorption and the shear as well. And that can lead to damage. So if you have a hip labral tear, that may lead to and is associated with premature hip osteoarthritis, right? And I like to go back and look in these studies because if you have more hip osteoarthritis, it doesn't always mean it's symptomatic. But a lot of these studies, when they say folks have hip osteoarthritis, it means they had a hip replacement. So essentially, if you have a hip labral tear, it does increase the likelihood that you get a hip replacement over the course of time, which means you're getting symptomatic osteoarthritis. Not everyone that has a hip labral tear goes on to get a hip replacement, but it does increase the likelihood of getting it. All right, looking at the anatomy a little bit more, I have another image. And in this image, you can actually see that labrum a little bit better. So you have the acetabular labrum, which you can see goes around the outside of the ball and socket joint, creates that suction seal. You can see that yellow fluid on the inside. And essentially when you're walking on water, right? You're walking on fluid. You can see how that helps to reduce some of the forces that go through the hip joint, reduce longer term hip osteoarthritis. And we'll talk about this in a minute, but folks that have FAI over the course of time may develop hip osteoarthritis. So sometimes I think about FAI being kind of like a chronic meniscus tear for someone who's going to eventually get knee osteoarthritis. For folks that are developing FAI, they might be going along that spectrum, right? It doesn't mean that when you have FAI, you're definitely going to hip osteoarthritis, but it can be the beginning stages of that. Some radiographic findings. We already mentioned a CAM morphology. So just to orient you a little bit, we have the femur, we have the ball portion of the femur, the femoral head, and we have the acetabulum or the socket portion on the pelvis. Then you have the labrum depicted there in pink. In the center image, you have CAM impingement. Essentially, we have extra bone on the neck of the femoral neck, right? And what happens is that that's going to create some premature contact of the ball against the socket when the hip goes into hip flexion and hip internal rotation. We can also have Pincer impingement, which is going to be extra bone on the acetabular side of the joint. And you can also have mixed impingement where you have Pincer as well as CAM. Now, we just went through a bunch of slides here, Kevin. Do you have anything to add at this point?
Yeah, I wasn't aware of the predisposition to hip osteoarthritis with a labral tear. I think that's interesting. I think it's just good for our frequent listeners who listen to our podcast on meniscus, like you said, to just draw that parallel that sometimes we see that this type of pathology is common and that it's okay, and we just keep working through it, which I do think is probably a good approach for most people. It's not like if you have a hip labral tear, you should just go get surgery. But it is important to keep in mind that probably grinding through a bunch of pain for years and years and years isn't the best thing. If you're not getting the resolution you want with physical therapy, there are options that we'll talk about definitely down the road. But it is interesting to hear too, and I wonder if that's true of equally of symptomatic and asymptomatic people and that type of thing. But just something to keep in mind, something to keep in the back of our head, and maybe something we share with some patients based on the context, and maybe something we don't because we don't want to scare them. But I think having that information is helpful. It's not just because it's so common, something we should definitely dismiss. It's important, I think, to keep in our mind and in our decision making. So, yeah, I don't think there's a great answer on how to manage that yet, but it's just good to think about.
Yeah, we'll talk about it a little bit in future episodes, but the idea behind getting a labral repair is you want to extend the lifespan of the hip naturally, right? So we'll talk about when we would consider that. But obviously, usually it's going to be rehab as a first line treatment. The other stat too is that just having CAM morphology increases your likelihood of total hip replacement. Having Pincer morphology doesn't seem to, right? And also the size of the CAM is going to dictate that risk as well, with a really large CAM being more of a problem. And I'll see some surgeons make a decision of whether or not they want to do surgery based on the size of the CAM. And I don't know if that's the right way to go, but it kind of makes sense, right? And I think the other thing to mention is that it comes down to absolute versus relative risk. So if you have CAM morphology, does it increase the risk of having a hip replacement? Yes. Now, relative risk is a decent amount higher. Let's say it's 5 times higher than the average person. The absolute risk is still very, very low. So let's say that your lifetime risk of having hip replacement is maybe 1%. If you have CAM morphology, maybe it's 5%. So largely, because you have a CAM morphology, like your risk of having a hip replacement is still very, very low. 95% of folks, now these numbers aren't exact, but I think this does hold true. 95% of folks are not going to have a hip replacement. But because you have CAM morphology, you are going to be more likely to have that than the average person who doesn't. All right, let's talk a little about asymptomatic findings, because these kind of blow my mind. They're always fun to look at, right? So in terms of CAM morphology, so they're most common in males with a history of sports competition. And essentially around 40 to 75% of male athletes are going to have CAM morphology. In a general population, that's only 5 to 23% of people. So if we're young and we play high intensity sports, the likelihood of us having CAM morphology is very, very high. So it's more or less normal, I would even say, for these folks, right? When we're talking about Pincer morphology, around 30% of young adults have Pincer deformities. They tend to be a little more common in females. This is going to be mixed depending on the study that you read. And there's no difference in rate of Pincers in athletes versus non-athletes. So we don't know exactly what's going on. It does appear as though if you play a sport, you're more likely to acquire that CAM morphology. But if you play a sport, it doesn't seem to change the likelihood of having Pincer morphology. The same thing kind of goes for labral tears. And these stats kind of blow my mind. I cherry picked this article, right? Just so you know, this is kind of a sensational one. But Briggs et al. In 2017 was looking at hockey players and downhill skiers. And they're looking at young athletes as well. And what they found is that 56% of athletes less than 15 years old had an asymptomatic labral tear, and 89% of athletes greater than 16 years old had an asymptomatic labral tear. Now, if you start looking at studies at hockey players in general, you'll see that they have very high rates of hip pathology and very high rates of asymptomatic hip pathology, right? Pretty high as well as in basketball, soccer, football, but something about hockey just seems to be a very high rate. And again, I just cherry picked this article. You're going to find other articles where the rates aren't quite as high, but it's more or less seems to be a normal finding. We talk about slap pathologies and throwers, right? And I've even heard smart folks like Kevin Wilkes say, hey, you have a slap tear, good job. You know, you're playing your sport hard. You just get a slap tear. And sometimes it actually helps you throw a baseball harder. So this slap pathology may be like an advantageous thing that we acquire by playing a sport that increases layback and our ability to throw harder. I don't know if that's exactly what's happening at the hip, but it does seem like if you play a sport, there appears to be a dose response. We'll talk about this later. The more you play a given sport, the more likely you are to have this hip pathology, but that's not always symptomatic, right? So just something to keep in mind there. Kind of interesting stats. Anything to say about that, Kevin, before we move on?
Yeah, that's super interesting. And I think it does make sense. And I think you do see that, like when you were talking about it, I was actually also thinking about slaps and throwers. Is it just seems to maybe be a normal adaptation in those sports for whatever reason, whatever the stresses are that are causing them to lay down a little more bone on their femoral head, you know, it is interesting. And if it's a normal adaptation to sport, I just want to, you know, would love to know when it becomes problematic. When does it become symptomatic? I know, like you had said, sometimes the size of it is probably a factor. But yeah, it's interesting. You see that a little differently, a little different mechanism, but with like Osgood Schlatters, and you get the bump on the tibial tubercle. It's just these young athletes that you don't get that if you're sedentary. It's an activity related issue. So a lot of these are activity related, and then you just weigh the pros and cons of activity versus a little extra bony growth on your hip. And I think no doubt would promote activity over that, even if it does become symptomatic. But I think if you want to treat hockey players as a PT, you gotta get really good at the hip for sure.
Yeah, for sure. Yeah, these hockey goalies crazy with stuff that they do. I can't like it makes no sense they don't have 100% hip labral tears, you know?
Yeah.
Yeah. And then, you know, to be honest, we tend to think about the ball and socket joint of the hip as a very strong, stable joint. It is, but it's just something Dave Tilley's talked to me about. But if you look at, let's say, gymnasts, the trail side leg and the split, in order to accomplish that split, you have to have partial subluxation of the hip. If you have, let's say, a hockey goalie and they have to get into extreme positions of the hip, maybe they're acquiring this hip pathology just to get into those positions they need to get into to play the sport. I don't really know. But the one thing I will say is that it seems like flexion and rotation is what causes this premature contact. Hockey players, like if you're skating, that's basically every single time you're taking a step, you're skating, right? You're getting flexion and rotation over and over again. And you're seeing a lot of pivoting in sports like soccer, basketball, so on and so forth. So it does make a lot of sense. If you do a lot of that, you probably have some Wolff's Law going on. You got some extra pressure on the ball of the socket. You're probably growing some bone as a result, right? So that does, you know, just check out. Some of the risk factors for acquiring FAI. So younger age, between the ages of 12 to 14 being the big ones, right? This is when people are developing. They're putting some strain on the hip through those periods of development, maybe creating some of those bony changes. Caucasian background is a big one. These folks are particularly susceptible to CAM morphology. I've heard this talked about by Stu McGill. For whatever reason, Caucasian descent, we have hips that potentially create more FAI. There's also some familial FAI, and we talked about this previously about arthritis. Generally, there's a genetic predisposition that may lead to more arthritis, hip arthritis, knee arthritis. Potentially the same thing is occurring with FAI. I always used to think it was crazy when folks came in. They're like, my dad had hip replacement surgery, so I'm scared about my hip, right? But as we read more and more research, I'm like, well, it does actually make a little sense, right? I'm not just thinking this patient's crazy in front of me. And then obviously high intensity sport participation during skeletal immaturity. So between 12 and 14, we just talked about this. Playing activities like hockey And there seems to be a dose response. So the more sport we play, the higher the likelihood is that we have FAI. So I also imagine it's similar to throwing sports. The more often you throw throughout the course of the year, the more likely you are to have some of this pathology. We probably have the same exact thing occurring for younger athletes. So I also imagine if we're trying to prevent some of these injuries, maybe we just make sure athletes are playing a variety of different sports. We're not overdoing it with anything specific, particularly at a young age, while these athletes are developing. But I also wonder if it's like throwing. If you don't throw through the ages of 12 to 14 and you don't have these changes, you're probably not going to be able to throw that fast. So I wonder if they have to play these sports in order to see these changes. Like, who knows, right? I'm just trying to think of if there is a correlation between throwing sports, because in throwing sports, if you're not throwing during these ages of development, then you're probably not creating some of these adaptations that make you a better athlete. So who knows if the same thing is going for the hip, but I think in terms of the research, if you look at the research on the shoulder versus the hip, hips is in his infancy. We're seeing a lot of, I don't know, correlation between the two. So it's just interesting to see. And who knows, time will tell a little bit about this, but maybe these changes are advantageous. We just don't know it yet. All right. Let's talk about some pathologies that may lead to hip FAI. And these are some of those things I learned in PT school and then kind of forgot about because I don't work in pediatrics anymore. But some of the big ones are leg, calves, Perthes disease. Essentially, you're not getting enough blood to the femoral head, and then this bone weakens and collapses. Essentially, the femoral head doesn't look like a femoral head anymore. And that can lead to more FAI. You can also have a slipped capital femoral epiphysis, or a SCFE. So essentially, the way this was described to me is like you have ice cream on a cone, and the ice cream starts to melt, and you hold the cone sideways, and the ice cream just tends to slip down a little bit, right? This is an adolescent injury to the growth plate where the femoral head is sliding down the femur. Think about the ice cream cone where the ice cream is melting and sliding off of the cone. We have an image of this here, if you're seeing this on YouTube, where you can see that femoral head is slipping off the shaft slightly, and they can correct that via pinning it back down. You also see more FAI in folks who have developmental dysplasia of the hip or acetabular undercoverage. We'll talk about this in a minute, but we'll talk about this a lot more in future episodes. So if I don't have that great bony congruency, a ball and socket, then I might end up having some more labral pathology over the course of time. Do you have anything to add there, Kevin, before we move on?
No, yeah, I think SCFE was a word that hasn't entered my brain in like 7 or 8 years. So that was a throwback. And I feel like I've had to have heard Dave Tilley say it a couple times, but yeah, interesting things to keep in mind, and maybe things that I wouldn't have thought about asking a patient during a subjective exam if they have any history of, any genetic type or acquired hip issues when they were younger, because that might go into helping rule in a diagnosis. But interesting, not something that was on my radar.
Yeah, I've seen a couple, like a handful, not very much, but I think part of our problem is a little bit of learn non-use, because if we ever have like a adolescent or pediatric hip, we send it immediately to Dave Tilley. Just he's very, very good at that, right? We see more of the adults, see some of that like middle school, high school. He sees a lot of the pediatric stuff. So yeah, those are interesting. They're still relevant, obviously. Okay. FAI and other injuries. Obviously, we talked about this a little bit more, but FAI does have a correlation with osteoarthritis. So particularly cam lesions with an alpha angle greater than 60 are correlated with increased progression of osteoarthritis. You can use alpha angle to grade how big someone's cam morphology is. So a lot of folks will diagnose cam morphology at an alpha angle of 60 degrees or greater, although some studies it's actually a little bit lower than that, somewhere between 50 and 60. But once you get into 65 or 70, that's largely considered a large cam morphology. And it seems like the larger cam morphology is going to be correlated with hip osteoarthritis and symptomatic hip osteoarthritis as well, like we talked about. So cam-specific FAI has been implicated in the development of primary hip osteoarthritis in as high as 25% to 50% of patients with observed degenerative changes. So when folks have hip arthritis, oftentimes they are presenting with cam morphology. And like I said, this is radiographic evidence, but also symptomatic hips in folks that have had total hip arthroplasty. So like I said, I think the basically the counter argument is like, oh, well, if I have cam morphology, it may lead to more arthritis, but is that symptomatic arthritis? Most of the studies that I look at, yes, it's not only symptomatic arthritis, but they actually call hip arthritis folks have had a total hip replacement. So not only are they symptomatic hips, they're symptomatic enough that person went to get a total hip replacement. So there's definitely a correlation there, right? This one is new, and I actually didn't know about this, and I have a couple ideas as to why this might be, but there is a correlation between FAI and hamstring tendinopathy. Essentially, those with FAI had more radiographic evidence of hamstring tendon damage, and those with symptomatic hamstring tendon injury were more likely to have radiographic evidence of CAM or Pincer morphology, right? My first thought was like, okay, well, maybe we have reduced range of motion at that hip because of some of these bony changes. Maybe that's leading to more tendinopathy locally. But my secondary thought was like, hey, if there's a dose response of exercise and CAM morphology as well as labral pathology, then there's probably a dose response for tendon pathology as well. We see this with athletes all the time. If you play a given sport, you're much more likely to have tendinopathy. So it might just be a correlation there simply because you're looking at folks that play a lot of sport. And because of that, they have more asymptomatic pathology or symptomatic pathology as well. But just an interesting thing I found in the research. And not sure why. Any thoughts there, Kevin, kind of seeing this?
Yeah, I think the one thing that just popped in my head is maybe biomechanically, instead of flexing so much at their hip joint, they're maybe like their open chain using their femur. Maybe they're doing a little more hinging, where you kind of get that compression of the proximal hamstring tendon at their pelvis, and maybe there's some movement compensations taking place. But like you said, if it's dose response with exercise, if FAI folks are generally more active, then we're going to see a tendinopathy, particularly with the hamstring in folks that are doing more activity like running, sprinting, specifically sprinting, that type of thing. I think it's fairly common in that group. So there might be some overlap in activity. Maybe there's some compensations biomechanically, but yeah, pretty interesting relationship that I didn't know existed.
Yeah, the other one I didn't mention, I probably should have, is that there's a very high correlation with gluteal tendinopathy. In some studies, it's like 80 or 85% likelihood. If you have gluteal tendinopathy, you also have FAI. So you have that as well. So I don't know if you're just seeing basically a beat up hip in these cases, which is taking a lot of stress over the course of time. I'm not sure. It might be something directly related to the biomechanics as well, just like you said, but interesting finding. All right, let's talk a little bit about pathophysiology, or that mechanism of injury. And to be honest, I didn't find a lot of good explanation in some studies as to how these injuries occur, but it does make a lot of sense, right? And we'll talk about what we think is occurring. So we just talked about this Warwick agreement. We think there's premature contact of the femoral neck up against the acetabular wall, right? And this increases with CAM and or Pincer morphology. We know that CAM morphology is going to limit hip flexion and internal rotation. So if someone has a large restriction in hip flexion or internal rotation, it's a good chance that's coming from CAM morphology, not, let's say, a capsular muscular limitation. So it's important you don't just ram through a bunch of range of motion, particularly in folks that are pretty painful. And this can pinch or rub the acetabular labrum. And I think the important thing to keep in mind is I've read a few studies on this, but essentially you're starting to get some compression of the labrum around 60 to 70 degrees of hip flexion, right? So when we flex the hip, it's very normal to get some contact of the ball up against the socket. And this occurs around 60 or 70 degrees. And then we get to about 100. Now we start to get a little bit of bony contact, and that just increases as we go into more hip flexion into rotation. But this is a normal motion, and it's not like anytime this happens, it's going to cause a problem. It's just that if we get too much of this over the course of time, it can lead to a problem. And having the CAM and Pincer morphology is going to increase some of the compression there, right? But you can also have FAI in the absence of abnormal morphology, right? And I just had a patient who had a hip labral repair, and she's a 50-year-old female, which is kind of an interesting age to get this, but she had an alpha angle of, I think, of 52, right? And they did call that a CAM morphology, although 52 in a lot of studies isn't even considered CAM morphology, right? So what's kind of neat is you can ask patients what their CAM was prior to surgery. And usually they're measuring this before and after surgery. You can have an idea of how much CAM there was, right? But if we're playing a sport, a high intensity sport like hockey, skiing, football, or soccer, and there's a lot of flexion of the hip combined with rotation at high speeds, high loads, high volumes across an entire training year, very little time for recovery, you might end up creating some labral pathology. Maybe you're creating some additional bone growth, right? Which may be a feed forward mechanism, more bone growth, more premature contact, more potential injury of the labrum, more opportunity to create irritation, right? Maybe not able to recover as well between sessions because you have much more compression over that area. So essentially over an extended period of time, the friction and stress generated by abnormal articulation may lead to damage of the labrum, erosion of joint depth, deterioration of the fibrous capsule, and resultant instability. So one of the new kids on the block in terms of hip pathology is micro instability, which we may cover over the course of time. But just like you might be seeing folks acquiring instability at the shoulder, and maybe it's not frank the way shoulder instability occurs where you have a dislocation, right? And then you have to go to the emergency room, get it, put back in place. In the hip, we might not be seeing this as much. Maybe there's some more subluxation or just more micro movement over the course of time because we have maybe some stretch of the capsule, some tearing of the labrum, more micro instability over the course of time. And then what's going on here sounds an awful lot like what happens with hip arthritis. So we have some injury to the cartilage, we have some injury to the fibrous capsule, right? And essentially what can happen for these folks is that they have enough joint damage over the course of time from FAI and labral pathology, then two things may occur. So A, the labrum might be so damaged that they can't repair it, right? And in some cases, they'll actually reconstruct it. They'll take a cadaver labrum to try to reconstruct it. But the other piece, if there's enough cartilage damage from FAI that's been going on for too long, then we know that a hip labral repair is not going to go well. So it is important that we try to pick up on this early, and we'll talk about this in later episodes, but if we're not having success with folks over the course of about 3 months with conservative care, we probably should send to the doctor to get some imaging. It's really hard to tell the difference between hip arthritis, FAI. They present pretty similarly. Moving on to diagnosis of FAI syndrome. How should we diagnose this? So based on the Warwick Agreement, we should be looking for symptoms. So does an athlete have pain, right? We also want to look for some clinical signs, so reductions in range of motion or positive special tests. We want to look for some imaging changes. So again, just like we talked about before, so CAM, Pincer, and also injection. So for these folks, they'll get an injection to the hip joint of corticosteroids, lidocaine usually. And if this is something to improve symptoms, rules in FAI. Any thoughts before we move on here, Kevin? I'm hitting you with a lot of stuff.
No, yeah, that's good. I think excited to get into the diagnosis. And I think everything you said on the previous slide about the repetitive contact over time, something we can't push through for too long because it can have these long-term changes to the joint, leading to micro instability, like you said, which I think is interesting because it seems like oftentimes in the earlier stages or when I see people in physical therapy who are non-op with what seems like FAI, is they seem, rather than unstable, more stiff. And there's, because usually you see that kind of teeter-tottering between less stability and like more stiffness type thing. So you tend to see people on the stiffer side instead of the unstable side are reporting feelings of instability. But I do think if we let that go for too long, that's what they start to develop. So that's interesting to hear. And I think it's similar to other pathologies, right? Like when you have issues inside the knee joint with like a torn ACL, you do get over time more and more instability, which compromises the joint. So it's just nice to see these principles kind of playing out in all the joints. So it's good to just get that overlap a little bit.
Yeah, not to scare any patients or providers, and incidents like this, because they're traumatic, they just stick out in our brains. But I've had a few patients now where they had a labral tear and they kind of opted for conservative treatment, and essentially they wait a year, 2 years, they go back to the doctor because their pain has not resolved and it's worsened. And unfortunately, they've developed osteoarthritis to the point where their only option next is to have a total hip replacement. So And that's not a great place to be in. And to be honest, this is not how it occurs for everybody, but it certainly has happened. So that's something that's in my mind, you know. And as a physical therapist, I think we want to sell exercise, and exercise is really good, but we also don't want to push exercise for too long. And if it's not working and they're developing more symptoms, to delay it long enough that they might not be able to get the surgery that would have been helpful from the get-go. So just a little food for thought, right? I mean, largely we want to try conservative care, obviously, but sometimes things go south if we wait too long.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
All right. History and physical examination. What are these patients going to say to you, and what are you going to find during that exam? So typically, as we said, this is going to be more common in physically active young adults. It usually presents as a slow onset of persistent groin pain, although pain location can be variable. Some patients are going to describe pain in the lateral region of the hip, the buttock, the thigh, or even the lower back or the knee. When folks have FAI and they develop labral pathology, almost all the labral pathology, I want to say it's 90 or 95%, occurs in the anterior superior part of the joint. So a lot of these folks will have pain right in front of the hip, and that's potentially because that's where that labral injury is occurring. A lot of folks will do the good old C sign where you take the hand and make a C out of it. You just cup the front portion of the hip. So pain in the anterior lateral region. Patients will say it's kind of deep right in this area, and they'll grab that front portion of the hip. And the pain is typically described as intermittent. It's not something that just hurts all of the time, right? Other common complaints associated with FAI and not just pain include clicking, catching, buckling, stiffness, giving way. And a lot of these folks will say that they're losing range of motion at the hip. It can be aggravated by minor trauma. It's not necessarily a car accident, but let's say you kind of jam it when playing a sport, rotating. Let's say you're throwing a baseball, and that trauma can cause some aggravation. It can also hurt with prolonged physical exercise. I've had some folks that have pain while running for a prolonged period. After a period of time, it starts to get worse and worse. Obviously, participation in a sporting event, there's a lot of cutting, pivoting, rotating. That can create issues, and long periods of ambulation. So if you have a hip labral tear, a lot of these folks, it hurts when the leg comes behind you into extension. It stretches the anterior labrum that's potentially torn, and that can be aggravating. Another really big one is pain with extended periods of time spent in a seated or resting position. So the big one I hear very frequently are folks have pain during a long trip. So driving, particularly in a car and not an SUV or a truck, just because cars, especially like a bucket seat or a sports car, you sit a lot lower, you're in more hip flexion, and that can cause irritation. Whereas if you sit in a higher seat, right? So think about a truck or an SUV, there's less hip flexion. It tends to feel a little bit better. So that's one of those questions I always ask my patients. Does it hurt for sitting for a prolonged period of time, particularly in a car that has a really low seat? And then I'm getting ahead of myself, but from a rehab perspective, we probably have to modify those sitting postures if those things are provocative. I've had some patients that are drivers professionally, And one of the biggest game changers for them is just having them sit on like an Eric's pad or something to elevate their seat a little bit. They go from being in severe pain all the time to the pain like virtually going away simply because you change your sitting posture. So that's just kind of interesting. All right, let's go over some clinical tests to help you rule in or rule out FAI. So I'm going through a study from 2020 called Combining Results of Hip Impingement and Range of Motion Tests Can Increase Diagnostic Accuracy in Patients with FAI Syndrome. And spoiler, I've gone over some more recent studies as well. But the most sensitive tests in that study, and these are helpful tests to rule out FAI, were the anterior impingement test with an 80% sensitivity, 26% specificity, and the failure test with an 80% sensitivity and a 25% specificity. So two things. A, I'm making a video on Monday where I actually go through these special tests. So you'll be able to see exactly what these look like, right? But B, these tests have a terrible specificity, right? So they're going to be really good for ruling out pathology, but not good for ruling in pathology. And this is more specific towards labral pathology. So when you have a failure test, great. Is that negative? Probably not FAI. If it's positive, not a really good likelihood there is hip labral pathology. One very specific test they mentioned in this study was range of motion testing of hip internal rotation in neutral. So essentially, you have a patient lay on their belly, knees together, knees bent to 90, then go to maximal internal rotation. And this had a 29% sensitivity, so terrible sensitivity, but a 94% specificity. And essentially, a positive special test was decreased motion with or without pain. So this is an interesting one. So people lay on their belly, check the range of motion, and if it's very limited on one side, that's a good sign they actually do have a labral tear within the hip. So kind of a cool one. I've been using this over the course of time. I think it's a pretty good one, right? In terms of hip impingement tests, at least in this study, one of the sore losers was the Faber test. And I wanted to bring this up because I think every physical therapy program in the United States at least teaches the Faber test, right? As one of those tests you use to kind of rule in FAI syndrome. And it had a pretty low sensitivity at 54% and an even lower specificity at 38%, which is not great, obviously. But if you look at other studies, so I actually have some other numbers listed here. And this was I believe, a systematic review from 2022. They showed the Faber test had a sensitivity somewhere between 41 and 97%, and a specificity somewhere between 18 and 100%. And what I will say is that this is not, we see this all the time, right? We see this in the shoulder with slap tears. We see this in the knee with the Thessley's test. One study comes out that shows the test is either awesome or terrible. Another study comes out that shows the complete opposite, right? So this is not surprising to me. It doesn't mean to me that I don't use a Faber test at all. It just means to me that we have to take these findings with a little bit of a grain of salt, right? Next, we have the Scour test, and this is coming from that study I just mentioned. So the study was actually 2023, non-operative management outcomes of FAI syndrome. And the Scour test had somewhere between a 50 to 100% sensitivity, but a 29% specificity. So again, another sensitive test is not very specific. The internal rotation overpressure test, which is essentially a failure test with an axial load, had a 75 to 89% sensitivity and a terrible specificity at 15 to 43%. Some other interesting FAI tests was a resisted straight leg raise test. So I think when folks do a resisted straight leg raise, they're thinking about picking up some sort of hip flexor pathology, a big one being maybe like a psoas tendinitis or tendinopathy. But a resisted straight leg raise test does have a decent sensitivity and specificity for ruling in hip labral pathology, depending on the study that you read, right? But in this study, it had somewhere between a 6 and 75% sensitivity and a 38 to 100% specificity. So what I tell my students I work with all the time is that when you do a resisted straight leg raise test that doesn't necessarily rule in hip flexor pathology, you may actually be picking up on labral pathology. Because a lot of those structures on the front side of the hip are probably getting provoked by doing a resisted straight leg raise. What I will say is that my patients that have FAI, as well as my patients have had post-op FAI surgery, resisted hip flexion can be very provocative. So just keep that in mind from a differential diagnosis perspective. Like, this is actually a test for hip labral pathology. And the other one I think is interesting is a Thomas test. So a Thomas test obviously stretches the front side of the hip. In this study, it had an 89% sensitivity and a 92% specificity. So actually really good in this study. And when you're doing a Thomas test, it's kind of the opposite of a failure test. In the failure, you're compressing all the structures like the labrum, right? You're trying to compress together that cam morphology up against the acetabulum, squishing or kind of pressing that labrum off of its attachment. In the Thomas test, you're doing the opposite. You're stretching the anterior labrum. So if I have an anterior labral tear and I do a Thomas test, I'm just pulling those surfaces apart. Maybe I'm creating pain because I'm doing that. That was a lot of tests there. Any thoughts there, Kevin? I think the first time I learned that those specific tests were actually ruling in labral pathology, it changed the way I think about diagnosing hip labral issues.
Yeah, 100%. And I think you had a good point that a lot of the universities teach all these clusters of tests for hip labral pathology. And I think we quickly forget the differences between sensitivity and specificity. And it's important to keep in mind because you don't want to do a fader test and get a positive result and tell someone that, you definitely have a hip labral tear, or, I think you definitely have FAI going on. Because that's not what that test says. It says that we can't rule it out. It's on the table. But that consideration is very important. And then I think the other good one you talked about that I'll see with these folks is that C sign type pain. And, you might get into differential diagnoses, but I think anytime we're considering a pathology of the hip, we're also considering the lumbar spine. And sometimes there's a radicular or a radiculopathy referral pattern. And that's something that we keep in mind. And it's very rare that those folks will do a C sign type pattern. So you can either wait for your patient to point to the area of pain, or oftentimes I'll just stand up and grab my hip at the side and say, is your pain mostly here? Or is it a little bit different location? And I think that's a pretty good one to get some good information, because if they do say, yeah, that's kind of exactly where it is, it structures your clinical exam a little bit, and then you're trying to rule out other kind of competing pathologies. So that's important to keep in mind too. But those are good tests. And then I know we've talked about this one, and anytime we talk about the hip, Mike Ryman's name will come up, and he is a big fan. I know he puts out a lot of good information on the hip as well, and these special tests and the sensitivities and specificities and stuff like that. So he's a great resource as well. And I think he was on that Warwick agreement, but I know he has a test, and I don't know if this is his personal opinion test or if it is one that you kind of talked about, but you have someone in a Thomas test position, and then you move the hip up and down through a range of motion, and you're looking for a reproduction of symptoms. And I know he likes that one in a cluster of everything else you just talked about for FAI. So maybe that's one that we could throw in the videos on Monday and just look at where he got that information from. But I know that's one that he likes for that pathology too, which is, if he likes it, I like it.
Yeah, I was looking at that test. It actually wasn't included in the same study, but it was also labeled under trying to diagnose micro instability too. So I'm kind of curious. I think these things probably coexist a little bit more than we might think. But yeah, that was a test for that pathology. A few thoughts, and we'll kind of get into this a little bit deeper. But yeah, that lumbar radicular one is big. I certainly have had one patient off the top of my head who had anterior hip pain, and he was actually scheduled to get surgery for FAI, diagnosed FAI, right? And he came to see me because his pain was so severe, and he had negative special tests for the hip, and he had a super obvious lumbar radiculopathy, radicular low back pain, and it was extremely obvious. So yeah, that can typically happen too. And the last point I wanted to make is that I see a lot of folks have a painful failure, right? And one of my thoughts is that, like, it's not a specific test, right? But it's not specific for hip labral pathology. I can't tell you how many patients I've seen that are Olympic weightlifters that get like an irritated, painful hip and the failure hurts, right? And if you send them in for imaging, it's probably negative. But my other thought is, like, how many of these folks just didn't develop labral pathology yet, right? Because I do like the failure test, and maybe it's not specific, but maybe it's not specific just because these folks haven't developed labral pathology yet, right? Because that's one of the diagnostic criteria generally for those tests. So what I will say is that fader is one of my favorites, but that's completely anecdote and biased. It's also very specific to the athletes I tend to treat, which are lifters that are basically in that deep hip flexion position all the time. So maybe that's a little bit more sensitive or specific towards those folks, right? Maybe the fader test is not going to be as sensitive or specific just because that's not the mechanism of injury. I don't know, right? If it's maybe let's say trail side leg of a baseball pitcher, that Faber test is going to be great because it actually picks up on that mechanism of injury, right? When they're getting external rotation extension, that's causing the labral pathology, where the fader test is maybe more specific to that lead side leg where they go into flexion internal rotation. So that's one of the things I think about as well. Right. So take that with a grain of salt. It's not like, because I think what happens, and this certainly has happened with the SLAP world, is that people look at one study and they're like, this is a terrible test, right? When in reality, it's like, well, it doesn't really respect that mechanism of injury at all. So maybe it's actually a phenomenal test for the right person, but a terrible test for the wrong person. And we just throw the baby out with the bathwater, right? So sorry, I'm getting long-winded, but I do think that's important because unfortunately, once you see a few or even one study that shows poor sensitivity and specificity, no one's going to study that test again. They're going to be like, this is a bad test. Why would I include this in future studies? It's not good. When in reality, it's like, maybe it's not the right test for that population. Right.
Yeah, that's a really good point. Like if we could get better at grouping tests to mechanisms where people are getting symptoms. But yeah, I think just one more point on that is I think what that test does is when we get a result, it changes our narrative to the patient. We don't automatically say that this is what you're dealing with and say something that we don't know to be true, but it definitely shows the patient that, look, your hip is irritated in this position, whether that means there's a certain pathology going on or not. And then, like you said, there's an easy way to sell modifying certain activities. Like, oh, you can easily see how this position relates to when you're playing catcher as a baseball catcher, or when you're in the goal as a hockey goalie, or even when you're sitting and driving for long periods of time. So why don't we modify this position? Because we can see right now it's super painful for you. Or we modify your squat. So maybe for a period of time you're squatting, just to parallel or above parallel, because this test is showing us how irritated you are in that deep hip flexion position. So I think it can change. It can be helpful for treatment, absolutely, and educating the patient. But I think we could just be careful about, how we describe what we think is going on, until we get better test clusters or stuff like that. So yeah, I totally agree with your point.
Yeah, I think, I was talking to Mike Ron about this the other day, but that word of impingement, right, tends to scare folks. Like, oh, if there's this bone there, this thing is never going to get better until I take that bone off. And I have talked to patients like multiple sessions saying impingement is normal. You don't have to worry about it. It's just sensitive. And once we drive that sensitivity down, you'll be fine. And for whatever reason, once they get that CAM morphology, pincer morphology into their head, they can't get it out. And even in patients with a very low alpha angle, same patient I was just thinking about earlier, she had a very small alpha angle, but she still couldn't, even after me telling her, like, it's okay, and you have a very low alpha angle, a lot of docs wouldn't even consider this a CAM morphology. She couldn't get that out of her head, right? And not everyone is like that, but I think it's the importance of our wording and then trying to kind of reduce any sort of negative impact you might have by de-threatening the pathology, right? Or like one of the things, and I don't know if you've noticed this, but I don't call CAM deformity anymore. We used to call them deformities. Now we call them morphologies, because deformity sounds like it's a bad thing. It might be normal, and we want folks to think like that's a problem, right? Kind of like bone spurs or, subacromial impingement, kind of the same thing. So it's funny, like hip impingement hasn't come under fire yet as a term for diagnosing FAI, right? But it may, just because shoulder impingement, that's been like roasted. You can't say that anymore. Like you're like, like you get burned at the stake if you use the term shoulder impingement, even though it's probably still occurring. Right. Subacromial maybe more internal, right? But you just can't say it because it's potentially making patients, scared or fearful. Right. So we're on a big tangent here. Sorry.
That's good. Yep.
Yeah. All right. Let's go in depth on some of these radiographic findings. So this was fun for me because I like to ask my patients about these radiographic findings, and I wanted to go a little more in depth on this. So this was an opportunity for me to do that, and hopefully I can share with that and have it make some more sense for you. But we talked a little about the alpha angle, which is basically a measurement how big a cam morphology is, right? We just talked about, let's say 50 to 60 would be a small cam morphology, if at all. But a lot of papers are saying like it's got to be greater than 60. And then if it's over 65, you might consider, okay, that's a large cam morphology. That maybe dictates what a surgeon will do or how fast they may prescribe surgery, right? And the way you measure this, and check this out on YouTube if you're listening to this right now. If you're driving, you're gonna have to pull over right now and pull it up. I'm just kidding. At a later point, maybe bring it up. But essentially, you draw a line through the femoral neck, right? And from there, the center of the ball, right, of the femoral portion, the ball of the socket, you draw a line towards where the femoral neck leaves the circle. So if you have a really big bump, cam bump, then that line is going to go a little bit closer to the pelvis and increases the alpha angle. So essentially, if you have a really large alpha angle, that means you have a larger cam morphology, right? And they use that as a way to measure how big that is. For a pincer morphology, you can measure this in a variety of ways. The big one's going to be a lateral center edge angle. You essentially have a vertical line through the center of the femoral head, and then you have another line towards the rim of the acetabulum. And that's going to measure how much over coverage there is of the socket over the ball. And you have a larger angle, that's more over coverage. And if it's greater than a 40, the greater than 40 lateral center edge angle, that's indicative of a pincer morphology. And the other thing that I found really interesting is that if this lateral center edge angle is too small, that's also a problem. So essentially, if you're under 20 degrees, you would be considered to have hip dysplasia. And if it's 20, 25, that'd be borderline dysplasia. And if you were, let's say, under 15, that would be severe, right? A normal person is somewhere between 26 and 40. But going back to this idea of hip osteoarthritis, if you have too little bone, that's a problem, because now we don't have good stability of the joint in dysplasia. If we have too much coverage, then that can create problems as well. Maybe not as much for long-term hip osteoarthritis, but for FAI, because we might be creating some premature contact. The other one you'll see, and I didn't know as much about this, but I'd seen it so much being talked about by doctors and seen this in, x-rays and, MRIs, was something called the tonnis angle. Sorry, I just burped right in the microphone. That was nice. So essentially, this tonnis angle is a horizontal line from the medial border of the acetabular sorsal. So I didn't know what the sorsal was, but the sorsal is basically a part of the joint. It represents the weight-bearing portion of the hip. You can kind of see it in white. It's that dense bone in white right there in this image. And essentially, you take the horizontal line from the medial border of the acetabular sorsal, right? And you can see the line where it originates on the left side. And they have another line to the rim of the acetabulum, which is the lateral sorsal. So it's basically from the medial sorsal to the lateral sorsal, and they take that angle. So the tonnis angle, less than 0 degrees, will represent pincer morphology. 0 to 10 is normal, and greater than 10 is going to represent hip dysplasia. So you'll see this tonnis angle as well as the lateral center edge angle as a measurement for both pincer morphology and hip dysplasia, which I thought was really interesting. So if you guys were kind of curious by looking at some of the radiographic findings and seeing these things, this is what they represent. So essentially it kind of shows how much over coverage there is, either lack or too much.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door, so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free Certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Also, another important diagnosis test you'll see is MRI, or more specifically, MRA. So MRA is going to be an MRI with contrast, and it's pretty much the gold standard for diagnosing labral pathology within the hip. I have seen a couple patients now where they have gotten a few MRIs that didn't show any sort of pathology, any sort of hip labral pathology. I've even seen one patient who had the wrong surgery for their hip. They ended up getting like a debridement for the rectus femoris. They thought it was maybe like some sort of stress injury to that area, or growth plate injury, or like a tendinopathy to the front portion of the hip, the rectus femoris. Got the surgery, nothing improved. Eventually, they had a doctor order an MRI with contrast, and they found a labral tear, and he had the right surgery and did pretty well. So this is something to be on the lookout for, because if you have a doctor that doesn't really understand this, you can have a misdiagnosis. And unfortunately, and this, we're getting better, right? But healthcare providers are classically very bad at diagnosing femoral acetabular impingement and hip labral pathology. So you just need to make sure you have a doctor who understands this. When someone has an MRI, unfortunately, you're like, ugh, got the wrong test, man. You probably needed to get some contrast in there, unfortunately. So if you're seeing that, make sure you're sending them to the right doctor and make sure they're getting the right test. So the structures that can be picked up with an MRI or MRA are going to be the labrum, cartilage, osseous morphology, so bony issues, subchondral bone marrow issues. So essentially, if someone's dealing with some hip arthritis and they're seeing some areas light up, they can find that with an MRI. Other structures that can be seen via MRI, MRA are ligamentum teres, the capsule, the psoas tendon, the glute medius, the glute minimus, hamstring tendons, and rectus femoris tendon. Sometimes these folks have, let's say, lateral hip pain. You're not sure if that's FAI or it's a gluteal tendinopathy. Maybe the MRI will help rule that in somewhat. So it does give you some more information. I'm going to pause right here just because we went through over a lot of different imaging. Anything to add at this point, Kevin?
Yeah, I think that's really good stuff. I think all those different imaging angles that we're looking at, like the center edge angle, the alpha angle, kind of next level stuff that are really good to know as a clinician. And like you said, it can kind of give you some lens into the severity of what's going on. You know, alpha angle, someone comes in with the alpha angle of 65 or 70, that's going to be managed a little differently than someone with 40 degrees, right? So those are helpful terms to know and a good reference. And I actually was unaware of the MRA as the gold standard for diagnosing hip labral pathology. So that's also really good to know, because it kind of made me think about, which we haven't gone over yet, but exciting to go over in the future for someone presenting with a spondy. They might come in and have had an X-ray and say that everything looks good, but they really need an MRI most likely. So it's good to know even here in the hip that an MRI is good, but we probably need an MRA just to really make sure that we're ruling in or ruling out that pathology. And, because it can be confusing. Like, okay, you had an MRI, it didn't show a hip labral tear, you're not getting better, what's going on? But I think having the appropriate test is important. So that was helpful. I wasn't aware of that. So good job.
Yeah, for sure. And like this day and age, people can kind of look up what CAM morphology means, and they go down this like rabbit hole of like needing surgery, so on and so forth. I certainly mentioned a few patients have had that recently, but if you can just educate them, like, look, you're under a 60. Like this isn't even considered a CAM issue based on, the study. Sometimes you can talk people down off the cliff a little bit just because we have some knowledge of these specific things, right? But on the flip side, if someone's dealing with like 65 plus and things are not getting better, I may be more apt to send back to the surgeon more quickly because I just want to make sure that we're doing the right thing long term for that athlete. So I think it is good to know those things, and it does help to kind of dictate your treatment and when you may refer out, so on and so forth. So good to know, like you had mentioned. All right, injections. So this is pretty interesting, and we have a local doctor, Dr. Wirtz. Shout out to Dr. Wirtz. We got him on the podcast at some point, but one of the things that he does a lot of, and you'll see this in medical literature as well, is that when you're trying to differential diagnose between the different types of injury at the hip, one of the things you'll see surgeons do frequently is they'll do a lidocaine injection with a corticosteroid into the hip. And essentially what they're trying to do is see if that reduces symptoms. So the idea is that the lidocaine has an immediate effect. Corticosteroid can take a little bit of time to kind of kick in. So in someone that has suspected FAI, they'll diagnose them via putting a corticosteroid with lidocaine in the hip. And if it reduces symptoms, two things. A, they think it is FAI and not something else. And also B, now they may be a better surgical candidate, because I've certainly had patients that seemed like they had FAI and then they had an injection and nothing changed at all. And now we're thinking, I don't think I want to do surgery for this individual, right? Because it might be something else that's creating their symptoms. Maybe it is more related to the psoas or something else. And sometimes, physicians will do diagnostic injections into those tissues as well to see if it kind of calms down things a little bit. So two things. It helps with diagnosis. Does it relieve pain? If it does relieve pain, it now makes you a better candidate for surgery. If it doesn't, then maybe not. And the second piece is it can be used as a treatment, right? And generally speaking, the results are short-term in nature, but you will see some studies. One we'll mention previously is Penicadol, where a large majority of patients will get better with conservative care, but a percentage of patients will go on to get a corticosteroid injection, and they will have longer-term relief. So if you have a patient, they're not doing very well with physical therapy, but then they get the injection and you continue physical therapy, they may have a better longer-term outcome because you combine the two, right? So I wouldn't say that you should dissuade patients from getting a corticosteroid injection because it's short-term in nature. And I think sometimes doctors are being accurate, but it reduces hope in patients. They say like, hey, we can give you a corticosteroid injection, but they only last for a period of time. That reduces hope for patients, and they feel like they shouldn't get it just because it's a Band-Aid. When in reality, if you get a corticosteroid injection and you continue with your PT, you may have a better long-term outcome. So I always tell patients like, hey, you're not making progress, but I think this is a good next step, and it can help with your rehab. It's not like this is just a short-term thing. Generally speaking, if you were to do just a corticosteroid injection, maybe not the best, but I think it can also be a pretty good treatment. But the other piece is that, particularly in older patients, and once hip osteoarthritis gets involved, they just get in this really bad habit of they get a corticosteroid injection, feels good for three months, right? And they wait a little bit, they get another corticosteroid, and then they wait a little bit, it feels better temporarily, and they just keep on getting more and more corticosteroid injections. We know that excessive reliance on this can cause cartilage degradation, damage, and that's not a good thing either, right? But I do think for a young, fit, athletic person, every once in a while getting a corticosteroid injection is not a bad thing. I'm pretty much pro these things for the right patient. So, all right, differential diagnosis. We're going to get into some of those concepts you were talking about previously. And I think the big one to be on the lookout for, and this goes for anyone that's coming in to get physical therapy, going to be red flags. The things like infection, tumor, and fracture. And we're not going to go into a big differential diagnosis on red flags in this lesson, but essentially fractures and tumors are recognizable via X-ray, CT scan, MRI. All the more reason if someone's not getting better over the course of time to send them back to the doctor to get some imaging. Things like septic arthritis, Osteomyelitis or soft tissue infection will typically present with acute pain, inability to bear weight, and fever. And labs such as a complete blood panel, CRP, and ESR can also help distinguish infectious causes. So first thing, always ruling out those red flags. The second biggest thing that I see misdiagnosed as FAI, or folks are misdiagnosing FAI as something else, is going to be hip flexor and adductor strains and tendinopathy. One of the big tells, and I see this so frequently, is if you have a strain injury, usually that's sudden, that's acute, that's all at once. If you have something that's more chronic in nature, that could obviously be a tendinopathy, but could also end up being FAI, right? The other big tell, and this is very specific in folks that have had strain injuries, is going to be tenderness to palpation. In folks that have FAI, sometimes we'll have some increased tenderness, particularly in like, let's say a TFL or rectus femoris, but usually it's really vague. And patients will say, I can't really put my finger on it. It feels somewhere deep. And it's probably because it is, right? In patients that have a strain injury or have tendinopathy, think of like your Achilles tendinopathy. Usually you can put your finger directly on it. Or strain injury. Like I've had a bunch of strain injuries and sometimes they're vague, but as soon as it happens, you're like, it's right there. It's right on this spot. You can tell where it is. And usually you can kind of poke around and find that spot again. For folks that have FAI, oftentimes you can't do that, although they will be tender in the muscles around the hip, right? So you really have to get good at palpation. We're going to show you this in the video on Monday. So stay tuned to the Fitness Pain Free channel, but essentially you palpate. You palpate the psoas tendon. You palpate the iliopsoas. You palpate the rectus femoris. We palpate the adductor longus, the pectineus, the adductor magnus. And if you can pinpoint what that pain is, that's probably going to rule in those diagnoses pretty well and rule out some FAI. But do keep in mind these things coexist. Having some hip flexor tendinitis or tendinopathy is very common in patients that also have FAI. So you might have hip flexor tenderness, maybe have some tendinopathy, and you also have FAI. Right? So be on the lookout for both. Like I said, there's like an 80-85% carryover for gluteal tendinopathy and FAI. So they can coexist for sure. The problem with hip dysplasia is that the special tests for FAI are also the special tests for hip dysplasia. So they present very similarly, right? And the same thing goes for something like osteonecrosis or avascular necrosis of the femoral head, has a similar presentation. And also hip osteoarthritis. So in those folks, they tend to have these same positive special tests. Oftentimes they're advanced in age and they have more stiffness or limitation. But the big takeaway is that these all present similarly. So if you're not making progress, we need to refer out over a period of time. Usually that's about 12 weeks, right? We already spoke a little about iliopsoas tendinitis or tendinopathy. So getting really good at your tenderness to palpation or doing some resisted strength testing. But just keep in mind, and the same thing goes for strain injuries, these are going to be positive oftentimes for FAI and with strain injuries and with tendinopathies. All right. So I wouldn't hang my head on like a resisted straight leg raise in terms of ruling in iliopsoas tendinitis. And the other one you see also coexists with FAI. It could be FAI, but lateral hip pain could be greater trochanteric bursitis, gluteal tendinopathy. Typically, these folks have lateral hip pain. They potentially have negative failure, although if you take someone into flexion, adduction to rotation, it does make the IT band taut over the greater trochanter and can elicit symptoms in gluteal tendinopathy. But generally speaking, this is more lateral hip pain with resisted abduction, right? We spoke about arthritis already. Another issue you may see is snapping hip syndrome. And there can be clicking and popping associated with FAI. But if the primary complaint is snapping within the hip, in the front side of the hip, this could be the iliopsoas tendon snapping up against the anterior inferior iliac spine. You hear this a lot of folks if they're doing, let's say, a dead bug, if they're just flexing the hip when they're on their back, the psoas is firing, it's getting taut, it's snapping the tendon of the psoas over top of the AIIS as you flex the hip back and forth. That's a sign that someone has a snapping hip when it's symptomatic. If it's snapping on the side of the hip, that could be the IT band snapping over the greater trochanter. So we want to be on the lookout for that. And the last one, like you had already mentioned, lumbar radiculopathy. So make sure you're doing some dermatomal testing, myotomal testing, maybe check reflexes, do a slump, do a straight leg raise. It'll be pretty obvious if you're dealing with lumbar radiculopathy. Like I said, I had a patient about to get FAI surgery because 100% of his pain was this stabbing pain right in the front side of his hip joint. And with imaging, he also had positive testing, right? So he had some cam morphology and some labral pathology, but he was also a baseball player his entire life. He's always kind of fit and active. So that was probably an incidental finding. So just make sure you're doing your due diligence. He ended up doing fine without surgery. And takeaway here, we already mentioned this, but there's a lot of overlapping symptoms. So FAI, avascular necrosis, arthritis present similarly, right? When in doubt, get it checked out. Send back to the doctor, get some imaging. This is one of those diagnoses that I think it's okay to send back to the doctor. I know that as healthcare providers, we're trying to save healthcare dollars as much as possible, but the last thing you want to do is miss one of these red flags because you don't want to like spend a little extra healthcare money, right? So send it to the doctor, particularly if you haven't had any change in symptoms for 3 months or 12 weeks, right? Refer out. Before we move on there, anything to add, Kevin? That was a lot of stuff.
Yeah, that's great. Just another one I'll throw in there. Just going through a lot of Chris Johnson stuff right now is a femoral neck stress fracture. So yeah, I think especially in distance runners, you're gonna see that unfortunately, and left untreated. If you go on to full fracture, that's bad. You can develop avascular necrosis like you had talked about. So if it's not super clear to you when you're going through your evaluation, like Dan said, it's okay to refer out. We don't want to miss a potential fracture or someone developing avascular necrosis on our watch. That would be terrible. So, not something we have to be fearful of, but just be diligent and pay attention to. But I think, like you said, I think oftentimes we can get a script from a doctor and say, treat for FAI. And like in the case you had, he's lucky he came and saw you and you found out it was lumbar radiculopathy type pain, which was awesome to catch. We never really want to rely on the script. It's good to keep in mind, but I think still going through kind of a robust clinical evaluation will be important, and having all those diagnoses in mind when you're working your way through and try to, rule in or rule out each one along the way, I think would be really, really important. So those are always important to keep in mind and kind of fun to go through on the eval.
Yeah, great point, Kevin. This actually happened to a friend of mine where they were having hip pain and they're a runner. And I think that's the first kind of red flag a little bit, just because runners can get FAI, but that's not really the primary mechanism of injury, right?
Mm-hmm.
So if you're a runner that has hip pain and it presents a little bit like a labral issue, then you might be dealing with a bone stress injury. I had a friend that he had kind of what seemed like FAI, and he wasn't getting any better, and he was going to the physician to get some imaging. And unfortunately, he fractured his hip before he got to the doctor. And he fractured it via gardening, which is kind of crazy. He's a runner, and he just kind of had this kind of groin pain that got worse with the course of time. Completely stopped running just because the pain was so severe. Went to the doctor, and before he got to the doctor, fractured his hip. And it's a life-altering injury, and this is not meant to scare physical therapists, right? Because I really love that saying that if you hear hooves behind you, you should think horses before zebras. And maybe that horse is some FAI, and the other one to think about is hip dysplasia in runners. But it could be that zebra. So make sure you do your due diligence and make sure that you don't have a life-altering injury because you missed this diagnosis. And, Kevin, I'm sure that we're going to do one of these in the future. I'd love to hear how you'd like to do your clinical examination of these bone stress injuries since you work with so many runners. But let's move on here because we're already spending so much freaking time on this. I just can't stop talking about it. All right. Next, we'll move on to everyone's favorite treatments. And I'm going to keep this a little bit shorter just because we're going to go much more in depth on future episodes. But I don't want to leave you hanging on obviously our favorite thing, treatment as physical therapists. So first, we'll talk a little about non-surgical treatments. And this is going to be first-line treatment physical therapy, right? And most of the studies on physical therapy for FAI are going to combine some sort of exercise, usually with activity modification. And in some of these studies, they may or may not include corticosteroid injections, right? And the research we have on corticosteroid injections for the hip show that most of these results are short-term in nature. But like I said, we have some studies, one by Pennick et al., that showed that incorporating a corticosteroid injection when conservative physical therapy was not working led to longer-term success in some additional patients, which is pretty cool, right? In terms of other injections for FAI, PRP, as well as hyaluronic acid, we just have insufficient evidence at this point. It's not going to be the first line treatment. We do have a local doc that we really like that specializes in injections. And essentially what I do is you find a good doc, and then if your patient's not making good progress, you can send them to that physician. Usually it's a physiatrist, and they can try some of these injection treatments if they don't want to try surgical treatment next, right? Just keep in mind, we don't have great research on this yet, so it's tough to advise patients and tell them the right thing to do, right? One of the things that kind of stinks with FAI, and this is cherry picked from one study, and I did this to kind of alarm folks and just prove a point. This is not what you see in every study. Conversion to arthroscopy has been reported to be as high as 70% of patients where they try physical therapy first, right? So physical therapy can certainly be helpful and depends on the study. We're just going to talk about a study in a second that was much more hopeful in this, but do keep in mind that a good chunk of patients may move on to getting surgery. And a lot of that probably depends on the sport they play, the size of that cam morphology, so on and so forth. We haven't parsed all this out, right? But what I will say is that we get a lot of patients at Champion that are post-op. They do extremely well, right? So if you're not doing well with physical therapy, getting surgery is not a bad idea. We'll talk about outcomes in a second, right? So patients should undergo a trial of non-operative management prior to surgery. Paper I'm taking this from said at least 6 visits over the course of 12 weeks. And that paper, I think, was showing that supervised physical therapy was better than just giving patient some education, a list of exercises to do at home. So conservative care, which essentially is physical therapy plus or minus injections, has been shown to be successful in approximately 39 to 82% of FAI cases. So like I said, I cherry picked that previous article. A lot of folks can do really well with just conservative care as well as injections, but you will find studies where they don't do quite as well. Prospective and retrospective studies have been shown an initial trial with these non-surgical treatments for minimum of 3 months can reduce pain and alleviate symptoms for up to 5 years, right? And this suggests the potential to delay or avoid surgical care. Thus, first-line treatment should be physical therapy, but don't feel bad if you don't solve everyone's problem. We know that a decent chunk of these folks will go on to get surgery, and they do tend to do pretty well. So usually up front, I try not to scare people, but I let them know, like, hey, there's a good chance this is going to get better. And if it doesn't get better, we have injections. There's something else we can do. And worst case scenario, you can get a surgery that tends to do really well with patients too. So I just try to be hopeful from the get-go and just let them know that a lot of folks do better, but I just don't want them to feel like, they're going to be a failure if they can't get better, conservatively. And I think a lot of PTs feel badly if they don't get these patients better as well. That's just kind of the nature of this condition. Not everyone can be saved, I guess, right? I mentioned this study by Pennick et al. This was in pediatric patients, so take it with a grain of salt, right? Adult patients may not do quite as well. What they found with physical therapy, and they also had a group that received a corticosteroid injection as well, is that folks made significant improvements that were maintained at 1 and 2 years, so much so that 76% did not progress to surgery over that time period. What they did find is that larger cam morphology were more likely to be treated surgically. Going back to that point we mentioned previously, that larger cam may mean that you need more surgery for that. And then 82% improved after injection. So 76% returned back to their prior level of function just with physical therapy. And then 82%, so essentially if you didn't improve with physical therapy, you got a corticosteroid injection. And then a total of 82% of those folks total improved with the injection. And then the last percentage went on to get surgery, right? So around 18% got surgery in that cohort. So from a return to play perspective, they didn't actually include return to sport rates as we typically kind of define them, which is always stressful and frustrating to me because I really want to be able to compare this surgery with some other surgeries, so the ones I know are like a home run and the return to sport rates are good. I wish I could just compare that to, FAI surgery, but at least in this study, they define success as being able to return to sport specific tasks. Like, what the hell does that mean? Did they get back to sport? Were they playing at the same level? Kind of hard to tell, right? But that's how they define return to play. So 82% of folks were able to return to play. And team sports were 3 times more likely than individual sports to return to sport. So I was a little lazy there. I didn't delve into what they meant by individual sports, but it might be something about the type of sport where folks were having a hard time getting back to. That's one of the things that they did mention within that study. So any thoughts there before we move on, Kevin?
No, that's all good. And I know in a future episode, I'll be talking about non-op rehab for these, and those are very similar type things I was seeing in my research. So yeah, I think always good to try the non-op rehab first, and just knowing that good surgery and good surgical outcomes are an option if needed down the road. So yeah, good stuff overall there.
Like to hear it. All right, let's talk about surgery again. I'll try to be brief. I'm terrible at being brief because we're going to go more in depth on this later. So what is surgery for FAI? So this can either be done open or arthroscopically. Large majority are arthroscopic. I think the only time you'll really see open surgery is when people are getting a PAO. So in the PAO, oftentimes they'll repair the labrum, but they're also trying to create more over coverage in patients that have hip dysplasia. So the typical surgery for FAI is going to be hip labral repair, debridement, or a reconstruction. So the big one that people do nowadays is hip labral repair. So in the past, debridement was more common. What they found is that it's just inferior to actually repairing the labrum. If there's too much damage to the labrum itself and they can't repair it, sometimes they'll reconstruct it, and they can use a cadaver graft in order to do this. I don't see this anymore, but when I was out in Denver, Colorado, there was a bunch of docs that did it. And one doc in particular didn't even do repairs. He just did all reconstructions. He just considered it a superior treatment, right? But I don't see that. You may see that from time to time. You'll also see a cam and or pincer reduction. So literally they go in there. If there's a big cam morphology, they shave it down, right? This image to the right here is on a patient of mine. This is an x-ray of his hip prior to surgery. And there's an x-ray on the hip afterwards. And he had a larger cam morphology. I want to say it was like 65 to 70. And they'll also tell you the alpha angle afterwards. I want to say he went from 65 to 70 down to like 50 or 55, something along those lines, right? If someone has cartilage damage associated with the labral tear, then usually they'll do a microfracture procedure. And if they do the microfracture, they're just poking holes in the bone, trying to create a little additional cartilage. And usually there's different weight-bearing restrictions for these folks. So only a little different in terms of rehab. Indications for surgery: A, previously failed conservative treatment, symptom improvement after intra-articular injection, an alpha angle greater than 65 would be an indication from the get-go. So based on this, is a Delphi consensus. So basically they just take a whole bunch of surgeons and they survey them when folks should have surgery based on radiographic findings. And they basically said, if there's a big old alpha angle, then it might be a reason to get surgery a little bit sooner. Contraindications for FAI surgery, and this is really important that you understand. Hopefully your doctor understands this too, right? So the importance of always having good surgeons. If you have an articular space less than 2 millimeters, then you're probably going to have a bad outcome from FAI. Essentially, you have too much arthritis. If you have greater than 50% joint space narrowing, or obesity that precludes access to the joint, or you have arthritic changes of a tonnis grade greater than or equal to 2. And the other one that's not in here, but if someone has hip dysplasia, docs are very concerned about doing some sort of labral repair just because of a fear that they'll just tear again because of the dysplasia. So if someone has dysplasia, then doctors are going to consider getting a PAO with an associated hip labral repair, right? And we know that arthritic changes generally lead to poor outcomes. And we used to think that if someone was advanced in age, they're going to do worse with a labral repair. We found that that's not actually true. The reason we've found this is that older patients generally have more arthritis. And if you have more arthritis, you have a worse outcome, right? If you're older without arthritis, then you'll have a great outcome from having FAI surgery. So good to keep that in mind. Arthritic patients tend not to do quite as well. What about outcomes? Well, you have generally positive reductions in pain and improved patient-reported outcomes after FAI surgery, although it's just going to vary based on the study that you read. In some of these studies, the surgery is not as successful as we'd like it to be. We'll save that for another lesson, though. Return to sport rates. Generally, there's a high rate of return to sport after contemporary surgery for FAI, around 87 to 93% overall, depending on the study that you read. And the rate of return to the same level of competition after surgery for FAI is 55 to 83%, which is really important to note. and I've listened to Mike Ryman talk about this, about the hip specifically, is that we have some decent papers that talk about return to sport rates, but we lack papers that talk about return to sport at the same level of play, which is going to be very important, because if you're a professional baseball player and you return to sport, but you can't perform at the same level of play, that's a bad thing. We've seen that in the shoulder with folks that have slap tears. It's like, okay, we can do a slap repair and maybe we can get you back to throwing, but we can't get you back always at the same level of play. And that's a problem. So we're much more likely to do conservative management in those folks. And the same thing might be occurring at the hip. So if you have a professional athlete, what's the right choice? Do we do surgery or do we do more conservative care? Because we need more high quality studies that look at return to sport at the same level of play to make that decision. Because in the past, we used to do a lot of slap repairs for high-level athletes, and we stopped doing that just because we've seen that the return to play at the same level is not quite as good. Any thoughts there, Kevin?
Yeah, I think that's a good kind of ending point there. Is it's always important to keep in mind what the patient's getting back to, and you wonder if you do this type of surgery on a hockey goalie, or depending on the sport, if they do get back to the same level. So definitely something to keep in mind and have a discussion with the patient and the surgeon, and try to figure out if the person you're working with is a good candidate or not.
All right. So now you should be a bit of an expert in terms of FAI, but let's say your patient does have hip flexor strain injury and you want to make sure it's not FAI. I have a video for you where we go over diagnosis of hip flexor strain injuries. Go ahead and click on that, and I'll see you in that video. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.